Welcome to Fertility 101, and thank you for spending some time this evening with us. I'm going to walk you through some of the basics of understanding fertility and some of the testing options and treatments that are available and what we do here at Ellume. So my name is Laura Meyer, and I am a reproductive endocrinologist or fertility doctor. We are all OBGYNs originally by training that undergo extra subspecialty training in reproductive endocrinology and infertility to help our patients with all things fertility related. Here at Ellume, we are a practice of 9 board-certified physicians who are all reproductive endocrinologists. And we have 5 different locations. We have 4 offices in Connecticut and 1 in Westchester County in New York. And we really offer the full spectrum of fertility services in-house. So we have our own ambulatory surgical center, endocrinology and andrology laboratories, embryology laboratory. We have an entire integrated fertility and wellness program, which we're very proud of. So we really believe in holistic care here. And we really personalize and individualize our care to each patient. We believe that everybody's needs and story is unique, and so we try to help all patients on their path to parenthood. So just to, again, go through some of what we do here. So we can help people with their initial fertility testing. We can do treatments that are more geared towards fertility preservation, such as egg freezing, sperm freezing, or embryo freezing. We do a full spectrum of infertility treatments, such as IUI and IVF, and we'll talk a little bit more about what these things are as we go on tonight. And we also offer services for people who need some additional help to conceive through egg donation or sperm donation, or who need to use a surrogate to conceive. As I mentioned before, we really are big believers in holistic care. We have an amazing acupuncture team here. They are great and help many of our patients. We also work with a network of reproductive psychologists and social workers in the area that help provide support to our patients. We have 2 amazing nutritionists who help our patients as well in their health journey as they're trying to conceive. And we run in-house support groups to help people through the process, because trying to conceive can sometimes be a challenging time, and we want people to have that support. All right, so to jump into some of the Fertility 101 basics, really I'm going to start with the definition of infertility. So what does that mean? The technical definition, according to the American Society of Reproductive Medicine, is either trying to conceive for 6 months or more if you're over 35, or a year or more if you are under 35, or really just anyone who needs some extra help or intervention in order to achieve a pregnancy. So like if somebody needed to use donor sperm, or if someone was a single person trying to conceive, anything like that, those are all things that fall under this definition as well, and people who may need some help in terms of getting pregnant. So obviously there's a few different things we need to have in place in order to create a successful pregnancy, and those are the egg, there needs to be sperm, and a uterus to gestate the pregnancy. So that brings us to some of the things that we do to work up infertility, or what are some of the things that we can check when we're trying to assess someone's fertility. So this is a diagram of the female reproductive tract. You can see the ovaries here and the fallopian tube and the uterus. And we need, in order for someone to become pregnant spontaneously or without assistance, the egg leaves from the ovary is swept up into the fallopian tube. Typically, fertilization actually occurs in the fallopian tube, and that's where an embryo is created. And then the embryo travels down to the uterus to implant and to grow there for the remainder of the pregnancy. It's also important to understand some of the basics of the menstrual cycle, understanding how the reproductive hormones work and how the cycle works in order to optimize chances of getting pregnant. So women have baseline follicles that have reached a certain point of development that are in the ovaries each month. And a follicle is a fluid-filled sac that contains an egg. So when you come in for testing here, you'll see oftentimes if we have you come in at the beginning of your cycle, we'll count the follicles in the ovaries to get a sense of how many are there. But of this group of follicles that you have in a normal cycle, what happens is your brain makes a hormone called FSH, which speaks to the ovaries and causes one out of that group of follicles to become the dominant follicle. That follicle grows over the first half of the cycle and produces hormones. It produces estrogen. And you can see here that estrogen rising over the first half of the cycle. And eventually that triggers the brain to release another hormone called LH, or luteinizing hormone. And that is what triggers the ovary to ovulate. In response to that surge, that dominant follicle that has the mature egg in it will release that egg. And the shell of the follicle becomes what's called the corpus luteum. And that produces estrogen and progesterone in the second half of the cycle that helps to support a developing pregnancy. If someone does not become pregnant that month, what happens is eventually the corpus luteum function wanes and kind of dwindles, and those hormones go down. And as they taper off, that triggers a woman to get her period and shed that lining that she's built, and the whole cycle starts again. If somebody does get pregnant in that cycle, that corpus luteum will support the pregnancy in the early part, and that pregnancy hormone causes the corpus luteum to continue providing estrogen and progesterone until eventually the placenta takes over. So when we talk about eggs and how those change over time for women, I was mentioning some of the assessment of egg quantity as looking at the follicle count. There's a couple of other ways to check what we call the ovarian reserve, which is the quantity, because the quality of the eggs, which is the other important factor, is not something that's directly measurable. When we're looking at when we're looking at quantity, excuse me, we can count the follicles, as I mentioned. We can check the AMH, or anti-mullerian hormone, which is a hormone that's made by the small baseline follicles in the ovary. So someone who has more eggs and more follicles will have a higher level, and someone who has fewer will have a lower level. And we can check the day 3 FSH, or follicle stimulating hormone level. That's a hormone that's made by the brain, and it communicates with the ovaries. So somebody who has fewer eggs in the ovaries may have an increase in their FSH level because the brain has to work harder to try to get things going in the ovary, and it starts producing more hormone. So that hormone we like to be ideally below a certain threshold. So these are all very common fertility tests that we will check when somebody comes in to be evaluated. It's important to understand that those quantity tests are really not predictors of spontaneous fertility per se, because the quantity isn't so important. If someone's trying on their own at home to get pregnant, they're typically releasing 1 egg a month. So in that setting, quantity is less important, whether they have a lot of other eggs or they don't have a lot of other eggs. Either way, their opportunity to become pregnant is the one that they release that month. But these are some measures that can give us a sense of kind of where someone is in their reproductive life, or if they needed to take fertility medications, how they might respond to them. If they did something like an egg freezing cycle or an IVF cycle, whether they might be someone who gets more eggs or fewer eggs. So they're important from that standpoint, but they're not directly fertility measures per se. And quality in a lot of ways is a lot more important than the quantity. Quality is mostly related to age and really has to do with the percentage of eggs that are chromosomally normal versus abnormal. A lot of it is the genetics of the eggs, and that's something that changes pretty dramatically for women over time too. And as women get older and in their later 30s and eventually their 40s, they get to a point where the vast majority of the eggs are abnormal. And so that's really one of the primary drivers why natural or spontaneous fertility goes down over time. And that can also make, or it can affect the success rates of fertility treatments as well. For those who have an issue with their eggs and do not have a sufficient quantity or quality of the eggs, we do also have an in-house egg donor program, and we work with some egg banks. So there are still ways to conceive even for people who have challenges in that area. So just expanding a little bit further on the ovarian reserve concept, as I mentioned, everybody's egg quantity is a little bit different, and we can measure it these different ways. But what's important to know is that as opposed to for men, where sperm is produced on a continuous loop throughout like their whole lives, essentially, for women, we are born with all the eggs that we'll ever have. So the peak that we have is actually when we're still in utero, and it's a normal part of reproductive biology that over time that number of eggs decreases. So by the time that we're born and then hit puberty and the reproductive years, it is declining. And then, the point at which we hit menopause is when we're sort of running out of eggs, so to speak, and there are very few remaining. So that is just sort of a natural process that occurs. So age, as I mentioned, is one of the most important factors. And again, a lot of that has to do with the genetics of the eggs and the percentage that are chromosomally normal or not. And also the number of eggs does decrease. So that can make some types of fertility treatments, a little bit more difficult, or can change success rates as women get older as well. And that's a part of normal reproductive aging, that those things change. In addition to checking the ovarian reserve, there are some other factors that we check as well, and we want to make sure that anatomically everything is okay. So a typical test that we do is called the hysterossalpingogram, or HSG, and this is a test of the fallopian tubes to make sure that they're open. So this involves putting a little catheter through the cervix and into the uterus. We do a speculum exam first, and we put in some fluid that can be seen on X-ray and take some X-ray pictures of the fluid filling up the cavity and hopefully spilling out of the fallopian tube. So you can see that happening in this image right here. We also do a saline ultrasound. That also involves a speculum exam and putting a catheter in and putting some saline liquid through that catheter and into the uterus, and taking some 3D ultrasound pictures of the inside cavity of the uterus. This gives us a sense of if there's any uterine pathology that we need to know about, or anything that's not supposed to be there, like a polyp or fibroid or scarring. We can also see if someone has an abnormal shape to their uterus. So these are all really important things. You can see here that this person has a very large polyp that could be inhibiting implantation, for example. So they may need to have that taken out. So those are the types of things that we can find with this imaging, just to make sure that everything is functioning the way that it should be. We also look at the sperm as part of the evaluation, and the way that we do that is a semen analysis. A man will produce a sperm sample and bring it into the laboratory, and our andrologist will evaluate it. We look at things like the count of the sperm, or concentration, which is the number of sperm in millions per milliliter of sample, the motility, which is the percentage that are normally swimming, and the morphology, which is the percentage that are normally shaped, as well as the volume in milliliters. And what we really care about the most is what's called the total motile sperm count, which is essentially how many swimming sperm are in the whole sample. And so we want to make sure that the sperm seems to be functioning the way that it should. If there are issues with the sperm, we will sometimes refer the male to a reproductive urologist who can do further testing. We oftentimes will repeat the semen analysis first, and then the reproductive urologist can do things like hormone testing of the male, exams, can sometimes treat with medications or surgeries or things depending on what the issue is. So they can help in that respect. So there are many different things that can cause infertility. And if you think about it, in order for there to be a pregnancy in a given month, there's kind of this whole series of events that has to line up. There has to be ovulation, and sperm has to get there, and fertilization, implantation. So really, any disruption of any part of that process, which involves thousands of tiny little biochemical micro steps, could prevent somebody from getting pregnant. So some of the things that can play in could be like an issue with ovulation. PCOS, or polycystic ovary syndrome, is the most common cause of that, but there are some other ones as well. Some of the declines in egg quality that we discussed before can make it more difficult to get pregnant. A problem with the sperm, something called endometriosis, which is when cells from the inside lining of the uterus travel to other places outside of the uterus that they're not supposed to be, and this can cause inflammation or sometimes damage to the fallopian tubes. Any other causes of fallopian tube damage can prevent egg and sperm from meeting. Any sort of uterine issues can also prevent implantation or development of a pregnancy. And sometimes we do all of this testing and it comes back as normal and we don't find a cause. And that is what we call unexplained infertility. And unexplained infertility doesn't necessarily mean that nothing is wrong per se, but it means that of the things that we can check, because we can check some of the things we talked about, sperm anatomy and hormones and those sorts of factors, that everything is functioning the way that it should. But we can't see or evaluate all parts of the process. We don't know what's happening with fertilization or embryo development or things like that. So some people with unexplained infertility may have an issue with one of those parts of the process that we can't always discern from the non-invasive testing that we have. Some people, it may just be taking longer and they fall on one end of a bell curve. I always tell my patients that this diagnosis of infertility in the first place is really a retrospective diagnosis. So an infertility diagnosis doesn't necessarily mean that somebody can't get pregnant or won't get pregnant. It literally just means that either it hasn't happened so far in a certain period of time, or that somebody might need some additional help to get pregnant. And those might be people who need to use a donor, gamete, or who are trying to conceive on their own or things like that. Those are all things that to keep in mind. So once we run the testing and have a sense of what the diagnosis is, or maybe why somebody might be having difficulty getting pregnant, then we have some treatment options in front of us. And we'll just speak sort of briefly about some of these today. This is a very basic overview, but we always like to counsel our patients more in depth about whatever treatment option we recommend for them. But we can do all kinds of treatments, all the way from sort of maybe the least invasive and most basic treatment. So something like ovulation induction, which would be helping somebody who has an ovulation problem to ovulate in a more regular way so that they have a better chance of being able to become pregnant. So I mentioned PCOS before. That is a very common hormonal disorder in reproductive age women where they typically do not ovulate regularly. So somebody like that might be able to just take a pill, an oral medication that helps to boost ovulation and then helps them to time intercourse accordingly. We also do things like intrauterine insemination. So that can sometimes be given in conjunction with a medication like the one I just described. But the insemination involves taking a sample of the sperm, washing it to pick out the best, or processing it to picking out the best swimmers, so to speak, and placing that sperm directly into the uterus at the right time in order to help with becoming pregnant. So that is sometimes done alone or sometimes with medication. We can also do in vitro fertilization, where we stimulate the ovaries and retrieve eggs and fertilize them with sperm to create embryos. We can do egg or sperm freezing, so fertility preservation. If for people who either may have a risk to their fertility, like somebody who might be undergoing a cancer treatment or something like that, or let's say a woman who just may not be at a point in her life where she's ready to start her family, may want to freeze eggs for the future to increase the chances of being able to have the family that she wants when she is ready. So she may decide to freeze her eggs. So those are all things that we can offer as well. We also offer donor conception. So we work with patients who are using sperm from sperm banks or who need a donor egg. As I mentioned, we have an in-house donor egg program. We also work with different egg banks. We can work with egg donor agencies. We also have a very large surrogacy program here. So there's some people who will need the help of surrogate to carry their pregnancy, and we are able to help them through the process as well. So there really are very many ways that we can help people, and we are very passionate about helping people to become parents when they are ready. So a little bit more detail about some of these treatment options. So egg freezing involves taking some hormonal medications. So when I was talking about the menstrual cycle before, we were talking about how the FSH hormone from the brain kind of stimulates the ovary to make a dominant follicle. Well, in an egg freezing or ovarian stimulation cycle, we are giving an FSH hormone in higher doses to try to get multiple eggs to mature at the same time. This usually involves taking shots. It's a small needle under the skin, what's called a subcutaneous injection, for a period of about a week and a half to maybe 2 weeks tops, and then culminating in a procedure called the egg retrieval to remove the eggs from the ovaries. And then any of the eggs that are mature can be frozen for future use. And then they could later be thawed and fertilized with sperm to create embryos when somebody is ready to become pregnant. These eggs are kept in liquid nitrogen at very cold temperatures, and they can sort of be frozen indefinitely, and then later turned into embryos when somebody is ready to have a baby. We also do intrauterine insemination, which, as I mentioned, involves taking a sample of the sperm and placing it directly into the uterus. So the sperm gets a little bit of a head start to where it needs to go. This is timed very specifically to somebody's cycle. Their ovulation may be triggered, so we know exactly when to place the sperm there. This is a very minimally invasive procedure. We do it in the office. It only takes a few minutes. It's also less expensive than some of the other treatment options. So we oftentimes may start with something less invasive like this when, when it is medically appropriate, and then if it was not successful, move on to other things. This could be a good option for someone who had a minor sperm problem that was not a severe sperm issue, or somebody who has unexplained infertility, as I was mentioning before. This can actually improve success rates even when we don't have a defined cause of the infertility. Someone who needed to use donor sperm might do an insemination. These are some of the more common use cases for this type of treatment. In vitro fertilization starts off much like the egg freezing that I described, in that it involves stimulating the ovaries to cause multiple eggs to mature at the same time, and then taking them out, taking the eggs out of the ovaries during the egg retrieval procedure. But in this case, the mature eggs are fertilized with sperm to create embryos, and then those embryos are cultured in the laboratory for several days, until they reach a stage at which they can be transferred or frozen or genetically tested, or some combo of those things, depending on someone's individual treatment plan. This is a more intensive and more invasive procedure. It does also have a higher success rate. And it is more expensive. So these are kind of things that all go into some of the decision making as well. But it can be the best option sometimes for people who either have a severe sperm problem, who have fallopian tubes that are blocked. This is a way of avoiding the fallopian tube so that they're not necessary for fertilization, or people who've tried other less invasive treatments and have failed them. These are some of the common reasons that people might choose to go this route. Donor conception and surrogacy fall under the general category of what we call third-party reproduction, which is any time that another person is involved in the creation of a pregnancy, an additional party. This is something that people come by for multiple reasons. For example, a woman who's unable to conceive with her own eggs may ultimately decide to pursue egg donation. That might be an option, especially for women who are in their 40s and who maybe have not had success with IVF or other treatments with their own eggs, may turn to something like egg donation, sperm donation for same-sex female couples, or for any single mom to be. Those are some reasons that people may need to use that. And surrogates could be necessary for anyone who's unable to carry a pregnancy. So that could be somebody who had medical complications during a prior pregnancy, who's had many failed treatments that are thought to, or like embryo transfers that have failed due to a potential uterine issue. It could be someone who's had their uterus removed because of a medical condition. Could be for a male couple who needs someone to carry the pregnancy. So there's lots of different reasons that people may pursue third-party reproduction. And we have a whole third-party team that helps these patients and supports them, including dedicated nurses, patient navigators, and finance people who can help through the process as well. So that is a very broad overview again, but a little bit of the full spectrum of what we do here at Illume. And here are some links in terms of helping people to schedule consults, and some more information about our team, and also just some more information about fertility testing and infertility and options and some of the things that we discussed here. And we look forward to meeting you, and are here to help in any way that we can. Okay, So one question, this is a good question. I have PCOS, and if I was to choose IUI, how do you determine when it will work? I have a regular cycle. So that's a great question. So typically in that scenario, it would be paired with the ovulation induction that I was discussing. So somebody might take the medication, their oral medications, some things called Clomid, letrozole. It may depend on the scenario. Usually we use letrozole for women who have PCOS. And so we would have someone come in for monitoring for blood and ultrasound, take this medication, which helps to get someone to ovulate and help a dominant follicle to grow, even in someone for whom maybe that doesn't always happen in a predictable way. We would monitor their cycle and then give them a trigger medication to trigger ovulation and then time the IUI based on that. So that's typically how we would address that. Another question, is there a way to increase your AMH? Okay, so no, not really. It's really reflective of the quantity of eggs that are there. So it is, and for all of us, that quantity of eggs does decline over time. Now, it is important to know and understand that the assay can be a little bit variable. So for example, somebody might, if you sent your AMH off to a few different labs in the same day, those values may not be exactly the same. They may be within a certain range, or if you sent it a few months apart, there is some variability there. So it could be that somebody sent their AMH and it came back at 1.2, and then they sent it a few months later and it comes back at 1.5 or whatever the case may be. That's not necessarily surprising. It doesn't necessarily mean that they got more eggs. It's just that there's some variability in the measurement. And the AMH itself is not the problem per se. It's just the measure of that egg quantity that is there, sort of more a symptom of the issue. And that quantity, again, is not so relevant as long as someone has some eggs and is not menopausal and is ovulating regularly. That AMH is not so predictive of their ability to get pregnant naturally or not, but it may play into their success rate with treatment, so that if somebody has a higher AMH and they need to do an IVF cycle, they might get more eggs, which means they might have a higher success rate than someone who's their same age and has a lower AMH and may get fewer eggs. So that's kind of where it's relevant there. Hope that answered that question. Is the egg retrieval process in IVF the same as egg freezing? Yes, the procedure itself is identical. So it involves sedation anesthesia. So we do them in our Norwalk office. And you receive propofol through an IV. It's a quick procedure. It only takes about 20 minutes or so while you're sleeping, with a vaginal ultrasound probe. We look in at the ovaries and we have a needle guide along the vaginal ultrasound probe, and it goes through the vaginal wall. So everything's done vaginally, no abdominal incisions or anything like that. Goes into each individual follicle in the ovary and drains the fluid from the follicles, and out with the fluid come the eggs. So that part is the same. And then if someone's freezing their eggs, just look and see of those eggs, which ones are mature and they're frozen. And they're just frozen as mature eggs for IVF. Those eggs are then fertilized with sperm to create embryos. So that there's just sort of a branch point there. At what age do we recommend sperm freezing? It depends a little bit on the situation. Like if there are certain medical conditions or things that might be expected to affect the sperm, that someone could benefit from sperm freezing, or if they have a really low sperm count, sometimes it's good to freeze what's there in case it continues to decline over time. The timeline for men as it pertains to sperm is different than women with eggs. As women, we sort of run out of eggs when we hit menopausal age. Men make sperm their entire life. Some of those sperm parameters do decline with age, but there still is potential for fertility even later. There are also some other risks to advanced paternal age. There are risks, increased risks of autism and schizophrenia and some other things called imprinting disorders and things like that. So those risks, the absolute risk of them is still low, even in older men, but it's a little higher than in younger men. But a lot of that is when you get even older, like 50s plus for men. So we don't always routinely freeze sperm for men automatically, but there may be some situations where it makes sense for individual people. Is it true that once you choose IVF, you always have to choose it if you want multiple kids? No, not necessarily. Many people end up doing IVF because they maybe have an underlying issue that made it difficult for them to get pregnant in the first place. So they may have a higher chance of needing assistance again in the future. But there are sometimes people who do get pregnant through IVF for one child and end up getting spontaneously pregnant later, depending on the cause of their infertility and things like that. So that doesn't necessarily mean that it's a definite, but there are many people who do go that route. If you have a blocked fallopian tube, can you still try IUIs? Sometimes yes, as long as at least one fallopian tube is open. So there is, I like to say, the beauty of the redundancy of nature, which is that there's a reason that we have two of certain things in our body. So you don't need two functioning fallopian tubes to get pregnant. People can get pregnant with one. So if both tubes are blocked, IUI is not an appropriate option. It's not going to work. But as long as at least one tube is open, that would be a potential option. Next question. Do follicles vary from cycle to cycle? They do. So if you do the antral follicle count in multiple months, it will be a little bit different each month. Most people hover within a certain range. Like it would be unusual for somebody to have two baseline follicles one month and 20 the next. Most of the time it's within a certain range, but it does vary a little bit. You have a new group of follicles each month, so it can vary a bit from month to month for sure. Let's see. Is there a minimum number of follicles that you require to proceed with egg freezing? No, there's not an absolute minimum, but somebody's success with egg freezing depends primarily on the age they are when they do it, because that's a proxy for egg quality, and the number of eggs that they get. So we try to assess for somebody based on what their ovarian reserve is. Like if they have a lower ovarian reserve, their chance may be a little lower than someone who has a higher ovarian reserve that's the same age, because again, the age is the determinant of the quality piece of things. So we counsel people about what their chances would be for different numbers of eggs, and then patients make that decision, but it's not as cut and dry as there being a cutoff per se. Okay, another question. For a first visit, will they assign a doctor, or can I request a specific doctor? Totally up to you. If you have a particular doctor in mind that you would like to see, when you call to make the appointment, you can let them know and they can schedule you with that person. Or if you're not sure who to see, you can always talk to the person who schedules you about where you live or what office you're close to or what you're looking for, and they can help you find a doctor in our group. So either way is fine. Let's see. If in your late 40s, about is IUI a safe procedure if you want to use your own eggs, not diagnosed with infertility and good AMH numbers. So with even something like an IUI, the AMH is maybe less important as long as someone has some follicles there and is ovulating. In the late 40s, the chances of success with IUI are exceedingly low. They're also, unfortunately, extremely low with IVF as well. So it depends on exactly what age we're talking about, but once you get to 45 plus, success rates could be 1% or less, unfortunately. So the success rates are quite low. Another question. If IUIs have failed, what is the success rate for IVF? So that really depends on somebody's age and their ovarian reserve. So success rates for IVF are very different at different ages. So, somebody who's 35, it could be over 50% per cycle. Somebody who is 45, it could be, 1%, low single digits. So it really depends a lot on age, and also within that, your ovarian reserve as well. So when you come for a consult, we can always do your testing, look and see kind of where you fall on the spectrum of things, and we can help give people personalized information about success rates and things so that they can, decide what treatment to choose, and kind of how they want to proceed. If someone does IVF and they do genetic testing of their embryos and they're able to get an embryo that's genetically normal, which is not what happens, that doesn't always happen all the time. Then once you have an embryo that you know is genetically normal and you're going to transfer it, you're talking success rates of, over 60%, 65%, somewhere in that range. But again, like your likelihood of getting that embryo, let's say that is normal or is healthy, is going to vary based on the age you are when you do the process. Okay, next question. Is IUI done as one of the first tests to know if you can get pregnant? So the IUI is not necessarily a test per se, it's more as a treatment. And unfortunately, it doesn't really tell us if someone can get pregnant or not. We do have plenty of patients who, unfortunately, if they don't get pregnant through IUI, may do really well with IVF and get pregnant that way. So having a failed IUI definitely does not mean that you can't get pregnant. IUI success rates also depend on age. At their maximum, for the youngest patients, there may be 15 to 20% success rate per month. So oftentimes, in any individual month, that's kind of the max of what the success rate may be, and it's lower for patients who are older. So some people may even try multiple IUIs depending on the situation, and then if they don't have success, move on to other things. But we do all the other tests first to see if someone is a good candidate for that kind of treatment or what kind of treatment is best. And then, do you recommend acupuncture prior to egg freezing to increase egg production? So we have an amazing acupuncture team here. They do wonderful work with our patients, and we have had many patients have excellent success with them. And there is, some data that suggests the positive effects of acupuncture for people who are undergoing various types of fertility treatments. So that is something that many of my patients do and have had a really good experience with and have found it helpful. And we're always happy to connect people with our acupuncture team if they're interested about learning more. All right. I think that was the last question. And yeah, I think that was it. But thank you all again for joining. Please feel free to reach out if we can be of help in any way. And I hope you all have a great evening. Take care.